Hello everyone, welcome back. Today I'll be covering regarding scaphoid anatomy and fracture. Started off with an introduction, function of scaphoid, anatomy of the scaphoid blood supply, scaphoid fracture examination, radiological investigation, differential diagnosis, management, and complication. As an introduction, the scaphoid is the most frequently fractured carpal bones, and these fractures are often misdiagnosed. Favorite MCQ question. Early diagnosis and adequate treatment are important to achieve optimal recovery and to avoid complication. This figure illustrates the X-ray of the wrist. The scaphoid is highlighted. Function of scaphoid. Its complex shape allows it to participate in the kinematics of both the proximal and distal row. Because of its offset proximal and distal articular surface, it has natural tendency to palmar flex with longitudinal loading. Because of this, extension of the scaphoid place progressively increasing tension on the palmar cortex of the curved waist of the scaphoid. Excessive extension or ulnar deviation of the wrist coupled with excessive loading mechanically predispose the scaphoid to fracture. Regarding the anatomy of the scaphoid, the scaphoid lies at the radial border of the proximal carpal roll. Scaphoid represents the floor of the anatomical snuff box. Parts of scaphoid: 1. The tubercle. 2. Distal pole. 3. The waist. 4. Proximal pole. This figure illustrates the anatomy fracture of the scaphoid. The commonest area that will fracture is at the waist region. The high risk of non-union is at the proximal pole due to the precarious blood supply. Next, regarding the scaphoid blood supply. It is a retrograde blood supply. Two vascular pedicles originating from the scaphoid branches of the radial artery. The dorsal branch enters via the small foramina along the spiral groove and dorsal ridge of the scaphoid. It supplies 70 to 80% of the scaphoid proximally, including the proximal pole. The volar branch enters via the scaphoid tubercle, supplies around 20 to 30% of the distal scaphoid. This figure illustrates the blood supply of the scaphoid. The radial artery provide the volar branch, and the proximal part is supplied by the dorsal branch. Remember, it is a retrograde blood supply. Scaphoid fracture examination. There will be an anatomical snuff box tenderness. Ulnar deviation expose the scaphoid waist for easier palpation. pain with palpation of the scaphoid tuberosity, pain over the scapholunate ligament with the wrist flex to palpate the proximal pole, limited painful wrist range of movement, especially forced dorsiflexion. Be aware of the wrist sprain that might actually due to scaphoid fracture. Differential diagnosis of scaphoid fracture. Number 1, scapholunate instability. It will be a pain and clicking in the wrist, tender just distal to the distal tubercle, and positive Watson test. Number 2, FCR tendon rupture or tendinitis. Number 3, radial styloid fracture. Number 4, dequervant tenosynovitis or radial styloid tenosynovitis. Number 5, CMC, carpometacarpal or basal joint arthrosis. Number 6, radioscaphoid arthrosis. Scaphoid fracture diagnostic algorithm proposed by the author. Patient with post-traumatic radial-sided wrist pain. 1. Anatomical snuff box tenderness. Number 2, scaphoid tubercle tenderness. Number 3, pain on axial compression of the thumb. Strong possibility of a scaphoid fracture exists when sign 1 or 2 or any combination of sign 1, 2, and 3 are positive. Then, next proceed to the radiograph of the wrist and special projections of the scaphoid. If there is a normal radiograph, spleen with dorsal wrist cast, and plan for MRI within 3 to 5 days. If visible, fracture detected on radiograph, we put on short arm cast and consider a CT investigation. Okay, everyone. For imaging, in plain radiograph, multiple views are necessary. Either posterior anterior PA view, lateral view, oblique, around 45 degree radial oblique, 45 degree ulnar oblique, the scaphoid view, ulnar division. For an advanced imaging, number 1, CT scan. Useful for acute carpal fractures, fracture displacement, malunion, non-union, and bone loss. Helpful in assessment of union. Number 2, MRI. In acute fractures, in assessment of avascular necrosis, and any ligament injuries. Number 3, ultrasound. Suspected carpal fractures, ligament injuries. Number 4, bone scintigraphy for acute fractures or avulsion fractures. Treatment of acute scaphoid fracture, non-operative management. There is an equivalent using a short arm cast versus long arm cast and spica versus standard cast. The duration usually for distal pole and tubercle fractures 6 to 8 weeks, waist fracture 8 to 10 weeks, proximal pole fracture 10 to 12 weeks or longer. For operative management, we can use either percutaneous pin or screw fixation, or open reduction and internal fixation. The indications for surgical intervention. If it's displacement more than 1 mm, lateral intrascaphoid angle more than 35 degree, height to length ratio more than 0.65, bone loss or comminution, perilunate fracture dislocation, dorsal intercalated segmental instability, any proximal pole fracture, and poor patient compliance. Complications of scaphoid fracture. Number 1, avascular necrosis, especially at the proximal pole. 2, malunion. 3, non-union. The location of non-union will determine approach to the scaphoid. For the waist volar approach, there will be a deformity correction and bone graft. Proximal pole, usually dorsal approach, need to consider the vascularized bone graft. Number 4, scaphoid non-union associated collapse, SNAC. What are the risks of non-union of scaphoid? Around 5% to 25% of scaphoid fractures. The risk factors include smoking, displacement over 1 mm, and vertical oblique fracture line. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.